Welcome to the Neuromodulation podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. On today's minisode, we welcome Dr. Shruti Agashe on behalf of the journal Neuromodulation, Technology at the Neural Interface, to interview Dr. Rod Taylor. Dr. Agashe is a practicing epileptologist, biomedical engineer, and assistant professor at Duke University. I'll allow her to introduce Dr. Taylor, and for your awareness, the video version of this interview is available on both Spotify and YouTube. Let's dive in.
This is Dr. Shruti Agashe. I am delighted to have the opportunity to talk to Dr. Rod Taylor. Dr. Taylor is a professor of population health research, co-director of Center for Excellence and Trials Collaboration, University of Glasgow, Scotland, UK. His former academic appointments also include being the first director of technology appraisals at the National Institute for Health and Care Excellence. He has published over 550 peer-review articles in the field of health services research and health technology assessment. He has extensive experience in health technology assessment, including membership of the UK NICE Technology Appraisal and Interventional Procedures Committee. Dr. Taylor, welcome. It's my pleasure to have you here.
Pleasure to be here.
Wonderful. The purpose of this is to educate our audience on what the journal is looking for, but also to provide them some of your experience based on your role as a section editor on the socioeconomic side in terms of what authors should be doing when they're preparing manuscripts, what should they be focusing on. One of the questions I have is, why is this important? Why is it important to not only study the efficacy, safety, but also cost effectiveness over the lifetime of any neuromodulation therapy?
I think that's a great place to begin, Shruti. So I guess I've got two ways of thinking about this. So one is wearing maybe what I might call my policy hat. This is perhaps less relevant at this moment in time in the US, but it's certainly the context of how we might approach this in UK and Europe. So if you could bear with me for a moment, I'll come back to the US in a sec. Essentially, cutting to the chase, if you've got a neuromodulation device in UK and Europe, if you want to have patient access, patients to be able to benefit from this therapy and clinicians to use it, you've got two hurdles. The first hurdle is a regulatory approval, as you say, based on efficacy and safety, hopefully randomized control trial data, showing that the intervention is effective against sham or some form of alternative current treatment. But then the big question we have in our healthcare system, which is publicly funded, the National Health Service, is, can we afford it? Is it good value for money? And the way that we assess that question is to look at a thing called cost effectiveness. It's as simple as that. And cost effectiveness, as the term suggests, is the trade-off between both the additional costs that either the health system has to pay, or if we go back to the US, the individual has to pay to have the procedure. But importantly, relative to the benefits that procedure would then give that patient. So I know that you work in epilepsy. So let's just take an example. So we've got a device, a new device for improving epileptic outcomes. So that device may cost more than what would be current standard of care. And the question would be, is the incremental cost worth the additional efficacy benefits that we evaluated earlier for that technology? And of course, that's quite a technical process, but essentially that's in a nutshell. And we have different technical ways of trying to assess that. One of the most common ways we do it in Europe is to use this cost per quality adjusted life year approach or QALY approach. And the important thing I think to really emphasize here, and now very much come back to the US, is that whilst traditionally cost effectiveness has not been a barrier to access in the US as much as Europe, I think primarily because insurers have been less willing to go down that path, if you like. I might just say that the US is perhaps more willing to pay for technologies than we are in Europe. But I can see that changing as time goes forward. But I think the important thing is that it's not about always looking at the cheapest being best. And I think that's a really important thing to take away from today. Often we think about, particularly policymakers, taking the cheapest option and the cheapest option's best. Cost effectiveness is formally saying we're willing to accept additional cost, but we need to get additional health benefit, such as a reduction in epileptic seizures in your area. And we want to trade off those two things together.
Very helpful. I see this in my practice. This is really a lifetime, right? Just a one-time cost benefit doesn't indicate what's going to happen for the rest of the life. And these are all chronic conditions that we're treating with
Brilliant.
neuromodulations. On similar lines, how does evaluating these socioeconomic factors in neuromodulation research, how does that really enhance the reader's understanding of health disparities?
Again, from perhaps a UK perspective initially, we are very into the whole area of potential disparity in socioeconomic. So we know that socioeconomic status, sadly, first of all, is a driver to can people afford treatment? Now, again, we are in a public setting where people often don't have to pay out of pocket directly. They paid for their healthcare through their taxation. So affordability isn't a big issue for us, but it can be in the US. Some people aren't insured. So it may be that if they want to access this new technology in your epilepsy space, they do have to pay for it out of pocket. So we need to think about costs, irrespective of efficacy and safety. But the one in UK, which again is as relevant in the US, is that we know that socioeconomics drives health. So those people who tend to be of lower socioeconomic status typically have poorer health outcomes. And that's a very complex thing. So it's driven by, if you don't have money, you can't afford to have healthcare, and then that gives you bad outcomes. Also, we know if you've got lower socioeconomic status, you may be less educated. So maybe your risk factor are less good. You live in accommodation. So in the UK right now, it's particularly cold. And one of the interesting things that we've introduced is a health warning to people's health because of the cold if they're not able to warm their home. So long story short, I think we need to be careful in healthcare society that are we making technologies available just for the well-rich? And therefore, in doing so, exacerbating the inequity in healthcare. And I think that's a really difficult one. And it's one that in UK we often very much grapple with. So when we look at affordability, accessibility, we actively think about, if we do approve this technology, are we actually unintentionally increasing that socioeconomic disparity?
Absolutely. Trying to decrease, at least in the future, is our goal. On the lines of disparities, I know a personal experience from a patient who just lost power at home, couldn't charge their devices, or just did not have a home for a short time, right? So thinking about those things when thinking about devices and making sure they have the support that they need, thinking about these things early on is certainly very helpful. And making the technology accessible, right?
And if I may, Shruti, I think what that really does then is to make us think about, some of these decisions are not just in the domain of healthcare.
Right.
They are in the domain of things like social care. And again, trying to connect our investment that we make around health interventions with people's social circumstances. I don't know how you find that in the US. I do, because we find it challenging. You certainly will as well. And I think we need to get better at doing that. But maybe that we need to think about, we provide payment to help that person's electricity not go off, and make sure that intervention then remains cost effective for that patient, because without it, they're going to get no benefit, right?
Exactly. I think some systems in the US we use loading data. We have devices that the patients need to charge, or iPads and things like that. And so certainly there was a gap in their care when I remember seeing them in the past. That definitely got me thinking so much more about these things because these are practical things that one often doesn't think about. And piggybacking on that, when, say, researchers are starting to think about their research, what they plan to put in a manuscript, do you have any advice on how they should implement the socioeconomic factors? When should they start thinking about these things? Any tools, anything you'd like to provide to the folks who are interested?
Great question. Great question. Again, I think I just want to say as a section editor, we are very keen in neuromodulation to take manuscripts in this domain. And probably we don't get as many as we might like. So we'll just put that out there now. So we do want to stimulate people to submit in this area. So I'm not a clinician, I'm a statistician and a health economist. So I think the first thing I would always suggest to researchers when they're designing the research, is there an economic consideration that they might want to include in their study? For instance, when I do clinical trials, we will not only collect the efficacy and safety data that you mentioned, but we will also look at things like costs and healthcare utilization. So we can then collect that data and report it, maybe in a separate manuscript from the efficacy and the safety. So there's the first one. Is it a relevant thing to collect cost economic data in the research study I'm undertaking? And I think clinicians don't always default to that because why should you? You think of efficacy and safety first. The second comment is that if you do have a manuscript where you've collected costs or socioeconomic data, is just to encourage you to try and integrate that into the paper. And I think one of the things that's out there is that there are reporting tools. For instance, if you're submitting a randomized trial, we will often reach out for things like the consort reporting guidelines. This is a structured way of reporting a randomized controlled trial. We have similar reporting tools in health economics. One of those tools is the CHRS, so CHRS. Don't ask me what the acronym stands for. I'll embarrass myself.
I feel like someone in Europe or UK designed this.
Spot on. It
Yeah.
was. So it sounds like a pub in Boston, doesn't it? And it probably is a pub in Boston. But anyway, it's also a checklist for economic evaluations. So again, particularly for clinicians that may be less familiar with this area technically, it's a useful reporting tool. And maybe the last one to scratch the back of sort of researchers like me is think about collaborating maybe within your institution if you have people who have got an economics background. And I think increasingly, certainly in UK, we in our department here in Glasgow, we have a team of health economists. So rather than having to scrabble about and learn how to do this on the job, is bring in a team of people who got some expertise in that area. And of course, if you're going to things like the NIH, you can then apply for the funding for them to support your work to do this. So yeah, I guess the message is think about it early. Are costs relevant? And if so, bring in hopefully some expertise and then think about that actively when you're submitting your manuscript, particularly in terms of reporting tools.
Those are all excellent points. I really enjoyed talking to you today, Dr. Taylor, and I'm sure everyone who's listening to it got a lot of information on just starting to think early, one, and understanding why these things are relevant and how to study them. We really appreciate your time, and I look forward to seeing you sometime soon.
Great. Thanks very much, Shruti, and thanks for listening, everyone.
Bye-bye.
Bye now.